Good morning, everyone. The topic for today's discussion is investigations of salivary gland disorders. That salivary glands or exocrine glands, they can be broadly classified as major salivary glands and minor salivary glands, and they can be subdivided as serous, mucous, and mixed glands. Disorders of the major salivary glands are relatively common with a large spectrum of underlying diseases. There are various techniques available towards the diagnostic approach of salivary gland disorders. Investigations can be summarized as cytometry, cytochemistry, diagnostic imaging, biopsy. Under diagnostic imaging of the salivary glands, we have conventional and advanced modalities. Under conventional, we have plain radiographs, cystography, ultrasonography, whereas under advanced, we have CT, CBCT, MRI, PET-CT, and cytoendoscopy. Look at them one by one. Cytometry. The term cytometry refers to the measurement of salivary flow. Salivary flow rates can be calculated from the individual major salivary glands or from a mixed sample of the oral fluids, which is called as the whole saliva. The main methods of collection include draining method, suction method, spitting method, and absorbent or sponge methods. The normal unstimulated salivary flow rate is 0.3 to 0.4 ml per minute, whereas the normal stimulated salivary flow rate is 1.5 to 2 ml per minute. Is where the sodium bicarbonate, potassium are estimated in the saliva. They can be tested both in unstimulated as well as stimulated saliva. The sodium in unstimulated saliva is around 6 to 26 millimole per liter, whereas in stimulated it is 13 to 80 millimoles per liter. These are increased in conditions like sialadenitis, radiation, Sjogren syndrome, and mumps. Bicarbonate in unstimulated saliva is around 0.1 to 8 millimoles per liter, whereas in stimulated saliva it is around 4 to 40 millimoles per liter. It is increased in inflammatory and irradiation condition. Potassium in unstimulated saliva is 2 to 22 millimoles per liter, and in stimulated it is 2 to 25 millimoles per liter. It is decreased in conditions like sialadenitis, mumps, Sjogren syndrome. Calcium in unstimulated saliva is 0.5 to 2.8 millimoles per liter, and in stimulated it is 0.2 to 4.7 millimoles per liter. It is increased in cases of sialadenitis, radiation, hyperparathyroidism. Amylase level is 0.4 to millimoles per liter. It is increased in cystic fibrosis, whereas it is decreased in starvation, acinar destruction, and sulfur. These are the conventional imaging modalities where only the two dimension of the gland can be visualized. This is the mandibular occlusal, panoramic, and the rotated AP view showing a rotated intraorally. We can use IOPR against the cheek with reduced exposure. Extraorally, we can use the panoramic radiograph, anteroposterior or posterior with puffed cheek appearance, and an oblique lateral view. The gland imaging, we have intraorally IOPR and cross-sectional mandibular occlusal view. Extraorally, again we can use panoramic, true lateral skull with tongue depressed position and oblique lateral view. Sonography is very important in imaging of salivary gland disorders because it helps one to distinguish focal from diffuse disease, solid from cystic lesions, and it can also be used as a guide for performing fine needle aspiration biopsy. The Doppler variety of ultrasonography can be used to assess the vascularity of the tumors, and it is also useful to distinguish glandular from the major salivary glands appears homogeneous hyperechoic echogenicity related to the adjacent neck muscles. Submandibular glands are more hypoechoic than the parotid glands. So this is the diagram which depicts the normal parotid in the ultrasonogram. Again the parotid. This is the plane for which submandibular salivary gland should be palpated, and the gland is highlighted here. This is the parotid gland where a normal lymph node is embedded within it. This is the parotid and the accessory parotid, and you can also see that the blue arrows mark the duct. And here we can very well appreciate the isthmus connecting the accessory and the main body of the cyst are generally seen as sharply marginated, echo-free, and it is represented as a dark area. This is the cyst of the salivary gland. So a benign tumor, they appear as well-defined margins, homogeneous echo texture, hypoechogenicity. They can be round or ovoid in shape, and calcification and vascularization can be appreciated. Whereas in case of a malignant tumor, it has an irregular shape, spiculated or well-defined margins, heterogeneous echo texture, vascularization, and presence of large cervical lymphadenopathy. Sonography is the technique where the dye is injected into the salivary ductal system. It is useful in identifying and localizing cellulite. It is useful for assessing the extent of ductal and glandular destruction, and also for appreciating non-calcified obstructive lesions like fibrin or mucous plug. The procedure can be broadly categorized as preoperative phase, filling phase, and emptying phase. There are three types of salography: simple injection, hydrostatic, continuous infusion, pressure monitored. This is the normal parotid gland after a xylography. This is compared to the tree in winter appearance. This is a normal submandibular gland after performing xylography. This is compared to bush in winter appearance. Xylographic interpretation. As we saw in the previous slide, this is the normal salivary gland. This is the snowstorm appearance which is appreciated in Sjogren syndrome. This is a filling defect or stricture, and this is the intrinsic tumor, and this is the extraglandular tumor, which is generally appreciated as ball in hand appearance. This is a sausage ring appearance which is seen in computer tomography. It is considered as the preferred initial imaging modality. For imaging of the major salivary gland, the standard neck CT protocol should be followed. What are the indications for CT concerned with salivary gland diseases is whenever we suspect calcifications or inflammatory conditions, we can go with CT. Whenever we suspect malignant processes, to evaluate the cortical bone erosion, dissection, as well as to evaluate the cutaneous change, we can go with CT. Contrast enhanced CT is useful for staging the malignant disease by assessing the lymph nodes of the pharynx and the neck. Coronal and sagittal sections of CT can be useful to assess the perineural spread, which is considered as a poor prognosis for patient. It is also useful to distinguish fluid-filled masses, that is cysts, from abscesses, whereas in abscesses we can see a characteristic enhancing wall. The American Society of Clinical Oncology guideline has recommended CT with the IV contrast for patients with suspicion of salivary gland cancer and involvement of adjacent bone. MRI, when we compare ultrasonography, CT, MRI, PET CT, and real-time elastography, the MRI has shown the greatest potential to discriminate malignant from benign neoplasms. And it is also useful to assess the malignant perineural invasion, intracranial spread, deep tissue extension, and marrow infiltrate or edema. The preoperative evaluation of salivary gland tumors for staging and treatment planning purposes can be done with MRI. Whenever we strongly suspect for malignancy, then MRI is indicated. To highlight the changes associated with lymphomas, which is seen as a complication in Sjogren syndrome, and for detection of extracapsular spread in regional lymph nodes. Lam et al. In 2015 conducted a study where MRI showed a sensitivity of 80% and a specificity of 95% in differentiating benign and malignant. Generally, low level of physiologic uptake occurs in normal tissues like the parotid, submandibular glands, and the tonsils. But this level is increased in cases of active inflammation and infection in benign and non-neoplastic processes like sarcoidosis and radiation-induced sialadenitis. And it is also useful for assessing the primary Sjogren syndrome. Here we can see a PET CT showing the normal parotid and the submandibular glands. This is the normal PET scan. Salivary scintigraphy is considered as the gold standard for assessing the salivary gland function. Both the parenchyma as well as the function of the parotid and submandibular salivary glands can be assessed after a single intravenous injection. It uses the technetium-99m pertechnetate as its intravenous agent. After injection, the agent gets secreted into the oral cavity, which provides the quantitative information on the gland's function. So we can see the parotid, submandibular glands and the thyroid showing the uptake. Salivary scintigraphy is indicated is when xylography is contraindicated, such as in cases of acute xylodenitis or iodine allergy, when major ducts cannot be cannulated successfully, and we can even estimate the severity of salivary gland involvement and functional change, which is not even accurately reflected by a morphologic change. It is used to assess the function following surgery, following radiation therapy, following radioiodine therapy. It is also useful as an aid in the diagnosis of ductal obstruction, gland aplasia, and Sjogren's syndrome. An abnormal salivary gland scintigraphy result is accepted as a part of 2002 American European Consensus Group classification criteria for Sjogren's syndrome, but it is not included in the 2012 ACR or 2016 ACR or EULAR criteria. Moving on to siloendoscopy, it is used to visualize the lumen of the salivary duct and their pathologies. It allows complete exploration of the ductal system. The main duct, the secondary as well as the tertiary ducts can be explored. It is both a diagnostic and intervention procedure. So it is indicated in cases of silolithiasis, stenosis and silodoctitis. Salivary gland biopsy. The salivary gland biopsy can be performed either from minor salivary gland or from major salivary gland. The minor salivary gland biopsy is generally done in the labial with the labial minor salivary glands, and it is the most commonly biopsied site. The indications are Sjogren's syndrome, amyloidosis, sarcoidosis, chronic graft versus host disease. But it carries complications such as lower lip numbness, which is appreciated in 6% of patients, and mucosal formation can be another complication. Major salivary gland biopsy can be done via extraoral approach or intraoral approach. Via extraoral approach, we generally perform with parotid and submandibular glands. Via intraoral approach, we generally utilize the sublingual glands. It is indicated in case of sarcoidosis for assessing the early diagnosis of mucosa-associated lymphoid tissue, MALT, and non-Hodgkin's lymphoma. Fine needle aspiration biopsy and core needle aspiration biopsy. The fine needle aspiration biopsy is done for the diagnosis of solid lesions. Elderly patients who cannot tolerate excisional biopsy can go with the fine needle aspiration biopsy, but it carries a risk for seeding of tumor cells by 12%. Core needle aspiration biopsy preserves the histologic architecture, which is not seen with the fine needle aspiration biopsy. Generally, we use 18 or 20 gauge cutting needles based on ultrasonography, but it carries a risk of seeding of tumor cells by 24%, which is higher. Conclusion: the awareness as well as the understanding of various imaging techniques as applicable in the field of salivary gland pathology should be very important for a dental professional. In order to reach a clear understanding of the pathology and making a definitive diagnosis and drawing a precise roadmap towards a successful treatment and better prognosis, understanding of these imaging modalities and investigation is very important. These are some of my references. Thank you.